Hi, I'm Gretchen Rhodes.
I'm Emily Masterson.
I'm Madison Torville.
And I'm Sarah Kucher.
And our project is about the impacts of patient-nurse ratios.
Our initial clinical question was, what is the best way for a nurse to minimize stress in a hospital environment? It was primarily focused on targeting methods that would best minimize stress and burnouts throughout healthcare. This is important to us because we will be facing work-related stress in our future nursing careers.
The population in our initial PICO was general nursing staff in a hospital setting, so that we had options to expand on different RN specialties. The intervention was to decrease the number of patients assigned to a nurse, and the comparison was the decrease in the number of work hours over a week. We realized after searching with both interventions that it was very limiting to find articles with both aspects incorporated. Our outcome was focused on minimizing daily stress, which was definitely an important aspect of nursing, but was hard to conclude with the limitations that the two interventions caused.
The initial searchable question was in regards to nursing staff working in a hospital setting. How does decreasing the number of patients assigned to a nurse compared to decreasing the number of work hours over a week help minimize daily stress of a nurse?
We proceeded to change our clinical question to focus on one intervention, which was decrease the number of patients assigned to a nurse, which we simplified to nurse-patient ratios. We searched for articles that included information about nurse-patient ratios and found a commonality among several articles: the quality of patient care. Limited articles showed information about nursing stress. Instead, the majority addressed patient quality of care and satisfaction, therefore leading to our new clinical question: what is the best way to improve quality of patient care in a hospital setting?
We eliminated the comparison because only one intervention was necessary, and with our research findings, we revised the outcome to increase quality of patient care.
From our revised clinical question and our revised PICO, we developed a new searchable question. In regards to nursing staff in a hospital setting, how does decreasing the number of patients assigned to one nurse help improve the quality of care of patients? The category of our question was therapy because we wanted to answer the effectiveness of our intervention, which was decreasing the number of patients assigned to one nurse. We also knew the outcome, which was the quality of care of a patient, would increase when we decrease the number of patients assigned to one nurse.
The terms we used to narrow down our search were the nurse-to-patient ratio and the quality of nursing care. The conceptual definition we found for nurse-to-patient ratio was a workload or staff concept that indicates the number of patients assigned to a nurse of an individual nurse. The conceptual definition we found for quality of nursing care was the degree to which nursing care services increase the probability of desired patient outcomes and reduce the probability of undesired outcomes.
The database we searched was CINAHL, and we found through UVM Data Medical Library. The subject headings that we used were nurse-patient ratio and quality of nursing care. When we first searched the articles, 276 were found, but when we limited them to research articles geographically specific to the U.S. and the date published, we found 19 relevant articles. Out of these articles, we found 2 that were useful to our research. From those 2, we used other articles that had also cited our original ones.
The first article's purpose was to investigate whether the size of the workforce has an impact on the survival changes of critically ill patients both in the intensive care unit and in the hospital. Patients in the ICU were designated mortality ratings on how severe their medical condition was, which was investigated in our analysis of the research. The sample population consisted of organizational data on 65 ICUs in total. The dataset contained information on 3,168 admissions. Out of these patients, 6,413 died in the ICU. The research design was a cross-sectional, retrospective, risk-adjusted observational study, therefore it was a level 4 evidence. The results suggest that the most severely ill patients are a subgroup that is most vulnerable to low nursing staffing. One of the statistics was the number of nurses per bed from 4 to 6 is to reduce the probability of mortality from patients with a predicted log odds of mortality of -3 from 0.017 to 0.016. This data represents approximately 1 extra death for every 1,000 patients because of the lack of sufficient nursing staff. If we look at patients with a predicted log odds of mortality of 2, then the reduction of the probability of mortality in going from 4 to 6 nurses is from 0.72 to 0.69. This represents about 7 extra deaths per 100 patients. Limitations in our study included patient participation was voluntary, therefore there is going to be a response bias. The data are cross-sectional, which limits the extent to which causal claims can be made, and variables on nurse staffing and workload are measured for the ICU as a whole, not at the patient level, meaning there is no direct patient-level measure of workload. Some strengths that are included was the use of 2 high-quality national data sets is one of the strengths, and then also the large number of units and patients analyzed in this study, as well as the use of appropriate methods for the structure of the data. Our conclusion is that the patients with severe medical conditions in the ICU have a higher mortality rating and therefore are the most vulnerable to low nursing staffing because of the severity of their illnesses and the effects of the nurse-patient ratio.
The purpose of the study is to observe patient satisfaction in regards to the nursing patient outcome. The sample population included 827,430 patients from 733 facilities in 25 states. Each state had to have a minimum of 10 facilities to maintain confidentiality. Also, each facility had to have a minimum of 30 respondents. The research design was a questionnaire that was not randomized, therefore it was a level 3 controlled trial. The results found that the hospitals in states with more working RNs per population see higher levels of patient satisfaction with nursing care. The strongest and most significant correlation was between RN supply and patient satisfaction with the experience of nursing care. The R and P values illustrate that when the ratio of working RNs to state population increases, perceived nursing care quality increases, and vice versa. It was also found that the supply of working RNs per patient was significantly and positively associated with the patient discharge process. Some limitations of the study was that they did not possess data from all 50 states, and the hospitals that voluntarily chose to benchmark patient satisfaction with an independent research organization may be systematically different than hospitals that opt not to participate. Some strengths were that questionnaires were sent out within 1 week of discharge, which ensured patients were able to fully recall and evaluate their experiences. They also maintained confidentiality and optimized representativeness. A conclusion is that, therefore, from the data that was presented, that patients in states with fewer registered nurses have greater dissatisfaction with the quality of nursing care.
The purpose of this article was to assess the effect of nurse staffing on the quality of care and inpatient care costs. The sample population was 421 hospitals from California, Nevada, and Maryland, which represented over 18 million discharges. The research design was a longitudinal analysis using hospital nurse staffing data in inpatient databases from 2008 through 2011. Therefore, the article was level 2 evidence. The results provide support for the value of inpatient nurse staffing as it contributes to the improvements in inpatient care. It also increases in all nurse staffing levels, led to reductions in adverse events in length of stay, and there were no reductions found in patient care costs. The article also found that if hospitals moved the mean nursing staffing to 1,000 inpatient days to the 75th percentile, there was a 0.7 decrease in length of stay and a 1.2 decrease in nursing sensitive quality indicators. Although we have multiple states, 78% of the observations were from California, meaning that the observed results were largely being driven from observations from that state. Clinical coding practices can vary across hospitals and states, which may have affected the cross-sectional comparability of hospital adverse event rates. The strengths of this study were that the findings were consistent with the findings of other studies and that large sample sizes were used. From this article, we can conclude that the mean number of nurses per patient is increased, the length of stay becomes decreased, and the patient quality becomes increased.
The final article we used was to clarify how wage, work, environment, and staffing are associated with burnout, job dissatisfaction, and intent to leave. The sample population was taken from 26,005 registered nurses from 534 hospitals throughout California, Florida, New Jersey, and Pennsylvania. The research design was a cross-sectional secondary analysis which used two-stage sampling design with surveys. On average, the patient-to-nurse ratio among these hospitals was approximately 5-to-1, and the average wage was generally higher in hospitals with better work environments or good staffing levels. Results related to job dissatisfaction show that nurses working in the hospitals with better work environments and better staffing have lower odds of job dissatisfaction. Another result was that an excessive workload exhausts workers' energy and makes recovery impossible. Effective and gratifying work that the satisfaction that comes from providing good quality care to patients becomes less attainable. The limitations of this article include the cross-sectional design, which limited our ability to draw causal inferences, and survey and wage data predated the economic recession that began at the end of 2007. In an environment where any job is difficult to find, the financial downturn could have tempered perceptions of less desirable aspects of the work environment. The strengths of this study include strengthening the basis for causal inference by accounting for an important potential confounder that had previously been omitted from most research, and this study also maintained confidentiality. We can conclude that although good wages are important, interventions that improve the work environment and maintain reasonable staffing levels may be more critical to attracting and retaining satisfied nurses in the hospital workforce. Although this article addressed wages for the nurses and the direct impact those had on their job satisfaction, it also related to nurse-patient ratios and work environment and how those affect patient satisfaction.
As you can see from the slide, we found many similarities and only a couple of differences among the 4 articles. One of the major similarities seen was through the limitations of each study. Articles 1 and 4 both use surveys and therefore have the possibility of having a response bias, while Article 2 uses questionnaires, but there is still a possibility of a response bias based on those who responded to the questionnaire.
Our recommendation is that there should be a nationally mandated policy stating the maximum number of patients assigned to each nurse. We chose this recommendation based off of the findings and results from all of our articles. We chose the grade of moderate because although we had previous knowledge of this issue, throughout our findings it was evident that more research would be necessary and beneficial for the studies of nurse-patient ratio.
Implications for professional nursing practice include nurse-to-patient ratios can be incorporated into practice by improving work environment to reduce workload on nurses, allowing more time and detailed examinations to be made with each individual patient. Increasing the ratio of nurses to patients would have a directly proportional impact on the financial aspect of healthcare due to increased costs of employing a larger staff. Future research should continue to focus on identifying the unique and particular contribution that nurses make to the quality of care for patients to identify safe nurse-to-patient ratios throughout all healthcare facilities.
Overall, we believe that nurse-to-patient ratio directly impacts patient satisfaction and quality of care within a hospital setting. These are the references we used to gather the information we presented in this video.